have contacted me with the Motiva distributors all over the world. Please ask for access to the educational platform. You get a password, and then you will have access to this presentation and all the presentations. You're going to access to live surgeries, recorded live surgeries from Preservé, from traditional breast augmentation, from Joy Dot, from mastopexis, with some of the best surgeons in the world. Mine is not there, so you can, it's really good. So we are going to talk about a little bit of Preservé. So I was talking this through the surgery, that the concept was, so now it's 2013, yeah. So in 2013, I do believe that Charles Ronquist was really pushing Motiva to do some sort of minimal invasive. And actually, to be fair, it was an injectable way of inject an implant and do a minimal invasive procedure. In 2016, we did a minimal invasive summit in Tokyo. That's when we did a kind of a brainstorm. Daniel was there. It was like 40 of us, I would say. Was a great event. And then we discussed what would be really what we needed. Because if we all think about the balloon and the injector, look, it's nothing really new, right? So Giovanni Botti uses a balloon to verify his axillary pocket for the last 20 years. He didn't use the balloon to expand. But there are papers in the literature of surgeons showing they use expanders to expand the pocket. One of our KOLs, Dr. Verdon from Belgium, he was injecting in the university implants with something like a pastry type of device to push the implants in about 10 years ago. He has a published paper. There are some Korean surgeons that published a paper with some sort of 3D printed injector, but was all over the place. And that was the problem. Everything was all over the place. It was just tools to facilitate the surgery. What Motiva did was to create a standardized ecosystem. And I think that was the real thought when we started doing this, is how we can make a procedure that is so easy that every single surgeon in the world can see one, do one, teach one. And that was really the key. And for that, we needed to create our own way of expanding this pocket. We needed to create our own way to inject the implants. So when we were doing the original injectors, and the people that come to here to Soleil, they see they were quite big because the physics of the ergonomics implant original didn't allow them to go through a very small channel. The problem is not to inject an implant, is that second that they go through a very small tunnel of the injector that stresses the implant and can explode the implant. So that was our first struggle. The original injectors, they were like very big tips and very short tips, and it was very difficult to do Mia for that. So we would have to still use a funnel to put the implant, and we didn't want that. So, and then when Motiva created the Ergonomics 2 implant, that when everything became possible, because the shell of the Ergonomics 2 implant is made with a special silicone that can really stretch and hold that pressure. So, of course, this is a company, it's a commercial. So, of course, there are the benefits. But look, the benefits are really the preservation of the circumventional ligament and the Cooper ligaments. Of course, everyone that does Motiva implants believe Motiva implants give soft breasts. I don't think it's a huge claim to say, oh, with Preservé, the breasts are softer. No, they are the same Ergonomics 2 implants as if you did Joy before. I think the key is preserving breast anatomy. And funny enough, I don't know if you noticed in the final result of this patient, with the picture before, I think the final result was not a traditional 195cc. I don't know if you could see that looked a little bit bigger than what you would expect for a 195cc implant. Demi looked like more like a 250. So what we saw starting with Mia is that because the ligaments are kind of pushing the implant a little bit to the middle, the breast optical illusion look bigger, in an optical illusion. So they look bigger. So even with Preservé, with the Mia, that's clear because also the implants have more projection. But even with Preservé, the breasts end up being, I would say, like 15% bigger than what you expect with the traditional breast augmentation. Yeah, preserve breast stability. Of course, the preservation of the peace of mind of the patient. I remember when I was starting my life as a surgeon, and then if you'd ask me 20 years ago, what's the best implant in the world? I would say it's the one I tell my patients is the best implant in the world. That was the mentality of the surgeon, right? So, because we never learned that there could be such of a difference. But I think that now with Motiva, there is a clear difference. That's what surgeons need to understand. Before Motiva, I really, like, I could put Eurosilicone, I could put Allegan, CY, I could put Natrel, I could put CPG. It's more or less the same. Like, but then with these softer implants, and of course now there are a lot of copycats, and they work okay too. So, but that was the game change. I think the first time someone told me, oh, a company did an implant that's super like copy of Motiva, many people were very upset. I was so happy because I said, really, that's the moment we really change this world. We really change the industry when people now are copying what we are doing, when before we're doing something completely different than everyone else. And of course, eventually that's the distributor's job to explain to you why the copycats are not as good as the original, right? And then also it's the type of surgeon you want to be for those at home as well. At home, some people are Turkish Bazaar Louis Vuitton bags, and that's okay too. Some people are the original thing, and it's the personality thing. We can never change that, right? And I'm not saying that the Turkish Bazaar bags are bad. They're kind of good actually, but it's not like the original. So that's the compromise. And I think we can spot every single point in every single copy of Motiva implant where there is a problem. And that's very interesting. And that's a conversation everyone that thinks about using one of these alternatives should ask the people. The greatest thing about Preservé is that we quickly expand the indications. So I remember when we started doing Mia, it took us, I don't know, 3 years to agree to do a hybrid Mia. With Preservé, we were doing mastopexy Preservés in less than 6 months. And actually, I think Mia, especially Mia, will completely change the future of mastopexys. I think that because with the high projection of the implants, once Motiva, it's coming next, a new platform with a little bit of a bigger implants, we are going to have such a nice projection that we are going to improve so much the ptosis grade 2 that we are going to bring back one of the surgeons that I hated the most, which is the periareolar mastopexys. But surgery that I completely eliminated from my life, I think they're going to come back big time, because with the high projection implants, we are able to give another 1 to 2 centimeters lift of the nipple, and then with a small sort of periareolar mastopexy, we are going to eliminate the inverted T mastopexys from ptosis grade 2. I think they will be only reserved to ptosis grade 3. And on top of that, we are now, many of us, we are using energy devices together with Mia and together with this mini mastopexis. So some of us are using breast tight. So we put the Mia, then we go under the skin and we use an energy device to tighten the skin. I use Endolift, which is the dual laser, and some people are using Renuvian. So what I've seen is that when we do this, when you do Mia with the ptosis grade 2, you do an energy device and you do a parallel mastopex, or even sometimes just a crescent moon lift of the nipple, you get such a acceptable lift. And I think in the future, that's another prediction. We will finish with ptosis 1 and 2 inverted T mastopexis. It will be only reserved for the weight loss patients and the really droopy breasts, because these implants will be so stable. That's the problem, the stability. They don't drop as much. So it's very easy to mold the tissue on top. And then, of course, with the hybrid, it works super well. The first case today, Dr. Vargas and I thought the same. I think in my practice, in Dr. Vargas' practice today, I think I would have done a hybrid preservé on that patient. Because, of course, when the patient is paying you thousands and thousands of euros, you want to push for probably the best. The problem was, and to be very honest, I wanted you to see the power of preservé, and the patient didn't want a very complex procedure. She wanted something, and because of her, she had bipolar. She didn't want. We discussed with her, like, add a lipo, time recovery to trigger something. So then ended up being good to do the preservé. And we wanted you to see the power of the preservé in terms of symmetrization and everything. But again, combining with a little bit of fat to really get that symmetry perfect, especially on the medial here and upper pole, I would put like probably 30, 40 cc in one side. And whenever I put fat, I always put 10 cc, 20 cc on the other side, because otherwise it looks a little bit different, the softness. Okay, so what we discovered after Mia is that the tissue preservation has all these levels: cellular, structural, dynamic, and functional. And then you can see, but what is the most important, it's not from preservé. So the cellular level of preservation is what we see on the FDA studies of Motiva, the low inflammation, the lower capsule. Then we have the structure, preserving the structures. The dynamic is what you saw today. So imagine we put an implant completely outside the base of the breast, and what did you see at the end? That the breast had the shape of a breast. And the implant was like completely, I would say, offline, right? And so I think that's really, really important, because with this, with the tissue preservation, with this balloon expansion, we recruit the tissue from other areas to the point of maximum projection of the implant. That's why we get a round breast, even if the implant is not around everywhere. But when you cut with the knife, you need to kind of center the implant a little bit more. Otherwise, you end up with either divergent nipples or things like all the surgeons have seen. And of course, functional, yeah, like the reality is when the anatomical breast implants were created, right, there was a commercial need to fit the anatomical implants. And then because the anatomical implants were the most expensive implants. And actually, some of my best breast augmentations were with 410s in terms of static, natural look of the patient standing up. They were beautiful breasts, right? But what happened was, especially on a little bit bigger sizes, these implants, the anatomical implants, don't fit well over the muscle. So the industry spent like literally 10 years, and that was a great work from Tabbets and Spear and Maxwell, telling us, no, breast implants need to be under the muscle. They didn't need to be under the muscle, but for TENS and CPGs of the world work, they needed to be placed under the muscle. I have no battery on the microphone. No, no, yes, okay. And so that was the problem. So we were all indoctrinated to put implants under the muscle to just to accommodate the need of buying anatomical implants. And then all this revolution started even in the US with the pre-pack reconstructions, right? And of course, there was another push from the meshes company, from the ADMs, right? To move pre-pack and use the ADMs and all that confusion. But going back to that, implants, they fit better in general when they are not under the muscle. And I said before, I do 30% of my surgeries still dual plane under the muscle. But if every day of my life, if I can have a good long-term result with an implant on top of the muscle, I prefer on top of the muscle. It's such a different experience for the patient. Okay, all of you home, I advise you to download. We all seen this, the Nature paper, how the low inflammation of Motiva. And this low inflammation was very, very important. So when I published the first Motiva paper, that was the experience from England in 2017, we had this paper that showed less than 1% capsular contracture. And I remember that was a scandal. Like, oh, you have no idea how many people accused me for faking the data or like this. I'll tell you an anecdotal story that was very interesting, because we published around 5,500 breast augmentations with Motiva in 3 years. Then one of the reviewers for the journal said, it's impossible, this is a lie. You should never publish this paper. So the editor, that back on the day was Fodna High, he contacted me and said, man, how are you gonna do this? Because they're saying physically, no one in the world could have done. So luckily, what Motiva did was to pull the invoices and serial numbers of all the implants. And we sent 231 pages, I never forgot, of serial numbers of every single implant we used in the study. And then the study was published. And then when Motiva published the FDA data, was a big redemption to me, because the FDA data was exactly the same data we published 10 years before, with less than 1% complication, no rupture, and so forth. There was one rupture on the Motiva data. So again, preserving the ligaments, and that's what you saw today. So you have the Cooper ligaments on top, and then you have the circumventional ligaments. So the implant needs to be exactly like this. I always make a joke saying the circumventional ligaments are like a nest. You put the eggs in the middle of the nest. And I don't know if you've seen this head scratcher thing that's like a web that you scratch your head. I don't know if you ever seen when you go away on holidays. They like to sell this. It's like a web, and then you put, and then you scratch your head like this. So these are the Cooper ligaments. They actually expand, and then they contract on the back of the implant. That's why there is a lot of stability. So, and then you see the points. So again, as I said during the surgery, it's impossible to guarantee a subfacial. Maybe sometimes when you're lifting, especially on the top, you are going to bring a little bit of fascia, but I think the implant is totally subglandular on Preservé technique. So this is what you saw, the tools, the sleeve. I love sleeves. So when I started, if I go on my Instagram, I published my first minimal scar surgery, I think in 2016. I did in Korea 1.8 centimeter breast augmentation through the IMF because the Koreans only wanted to do axillary approach. In Asia, that was most common. And I was telling them, no, I'm going to make IMF that the patient will be happier than the axillary. And I was sweating like a pig to be able to put the implant through for such a small incision. It was a 245 cc. And it was a very little Korean lady. But since then, I always said to people, I was never a big believer of no touch. I was never a big believer of 14 points. I used to make presentations joking, saying, I believe in 1 point, not to use textured implants and using low inflammation implants like Motiva, especially Motiva back on the day because that was the only one. But for you to do a small incision of 2.5, 3 centimeters, and put a 300 cc implant, you have to have a sleeve. Otherwise, it's really hard. And you end up fracturing the gel of the implant. You don't fracture the implant. How many times you removed an implant that had a big dent in the middle? Have you seen that before? That's a gel fracture. That gel fracture did not happen back on the day when the surgeon put that implant. And it stays there. The gel can fracture, but not break the shell. So you see, the implant selection, you're giving all these tools, like as I used to do define the position of, and it's very nice. They're single-use tools. They come in the kits, and then you position according. So as I said, the way I do is when the breast is very symmetrical, perfect, nipples perfect, I do a 6 o'clock incision. I go right in the middle, and I place the implant exactly behind the nipple, because the breast is already perfect. So I don't want to change the anatomy of that breast. I don't need to make that breast superior medial because the breast is already perfect. So why I'm going to play God and change the shape of that breast? But when in a case like today, the breast is lateral, I need to recruit from lateral to medial. The breast has a symmetry on the upper pole. Then I do this Preserve 1.5 or 2.0, where you do an incision at 7 and 5 p.m., and then you put the balloon across and more medial. So not every key fits every lock, so you learn how to do that. This is our channel dissector that makes sure you have enough space and a homogeneous space. So another question that surgeons ask me, like, okay, what if I buy a tissue expander and then I do a little tunnel with my bovie until the top of the breast, and I put a balloon, a tissue expander, and I expand, and I put my implant with the funnel. So what we saw, especially with Mia, is that the channel dissector, the homogeneous dissection of that tunnel, is very fundamental to the expansion of the breast. When we started doing Mia, we did not have this tool. We had almost like a facelift separator, like a duct that would open to do the tunnel from the top to the bottom. And in some cases, we saw where the tunnel was thinner and thicker, especially on very thin patients, that you could see that kind of little irregularity, or you could touch that when you put the implant, you almost like a lump where the tunnel was thicker, where the tunnel was thinner. So creating a very homogeneous tunnel is one of the reasons why using the tool is important. The second thing is that you saw with the balloon has a guide that precisely puts the balloon exactly open on the same position on the top of the breast. If you try, even guided with a forceps or with something to put an expander on the top of the breast, you're going to fold the expander. The expander is not going to be on a straight line. And then when you start your expansion, you're going to get erratic expansion in the first 3 pumps until the expander pushes back. So you end up having maybe one pocket a lot higher than the other. So the reason why we have the tools is for precision, because it's already very difficult for a surgeon to think outside of their normal thinking and do the balloon expansion and this type of surgery. And then if you start having pockets looking like this, you're going to really not believe in the technique. So we wanted to have, as I showed with the Preservé, you have the ruler. You make sure that the end of the balloon is at exactly the same distance from your IMF incision on both sides. You want to make sure that the balloon is completely open, homogeneous through a homogeneous tunnel. That's why we did it. Because promise you guys, it would be much easier for us to say, no, just put your finger like this, and like this is not a standardized reproducible surgery. Of course, there is always a surgeon that will develop a skill and he will be able to do whatever he wants. But this is not a surgery that, if you do like this, you cannot change the world. When you do with the tools, you first learn how to walk, then you run, right? So that's why we created a procedure, which was me and Preservé, to completely change the way patients have breast enhancement. That's why the tools for me are really, really important. And then, as you can see, the guide. So the balloon, whenever you put in, it's always in the same position. It's always open. It's not like folded. And then when you start, you're going to see, we did this before, the expands towards the up. But when he's fixed on the tool, it expands always on the same direction. And then you have the handheld pump. To be honest with you, when I do Mia these days, I prefer to expand with the syringe. I don't use this much, because I use the syringe and I do 5 times 50 cc's, and then I think I can control better my expansion then, because sometimes the hand, or you really needs to do something that Charles does very well, which is to connect the syringe and the 3-way tap and measure the amount of air that each person of your team delivers. Some nurses deliver 35, some 40, some people 45. So to guarantee that the expansion is homogeneous, you have to measure. So I use the syringe, so it's easy. And of course, the sleeve. As I say, I use sleeve for every surgery, even under the muscle surgery and anything. Of course, you all know about the ergonomics too, and the big change was, so now we have the true monoblock plus, we have the super silicones, and you have the blue seal plus. One thing that Motiva doesn't talk much, and I think Motiva should talk, is the gel bleeding. Every silicone in the world, every breast implant in the world has gel bleeding. But the only implant that's close to zero are the Ergo 2. And I think in the future, we are going to learn that all these problems that we're living, including capsular contracture, are because of gel bleeding and the inflammation caused by little particles of silicone that bleed through the gel barrier. I'll tell you another story. So going back to how the industry convinced us to go under the muscle and everything. So when Patrick Maxwell created the 410, if you read the patent of the 410 from Allergan, the patent says to mimic the surface of a polyurethane implant. Because if you ask Patrick Maxwell, he would say, I wanted softness with immobility. That was the goal of the 410. He created the biocell surface, which was a rougher surface, so the anatomical implant would not move, and wanted to be soft. I always joke with Pat, I hope he's watching, that in the softness, they failed miserably because the anatomical implants were hard, because they had to be like form stable to keep that position until the ergonomics implant came, and then it could have more silicone on the bottom independent of the position. But the immobility, sure, they could achieve at the cost of high inflammation, right? So, but when they launched the texture, the biocell implants, the original ones, what happened was the first breast implants, the smooth breast implants, they did not have gel barriers from the 70s. So they had over 20% capsular contracture. Okay, so these implants were the implants that you would put on a table on a piece of paper. You come back 2 hours later, and the paper would be a little bit wet. The original smooth implants from the 70s, the original breast implants. Then, when the industry in the 80s created the textured implants, all the textured implants had a gel barrier. And then they were never thinking about capsular contracture. But of course, once they put the gel barrier and they compared the data from the 80s and 90s to the 70s, there was a big reduction in capsular contracture. But not because the texture reduced capsular contracture, but because they put the gel barrier. And if you ask them, they will say, yeah, well, we didn't know. But we used to the benefit of the texture. But it was the gel barrier. So now, with the Blue Seal Plus, we really have an implant that has minimal gel bleeding. And I think this will be the reason for Motiva have and will have 0 ALCLs. Motiva will have very minimal inflammation, and Motiva will be the implants that will, in general, in the long last in the breast amidst all of the other brands, because more than this, in my opinion, or in the same level as the silk surface, the architecture of the surface, the 0 gel bleeding plays a very important thing on the capsular contracture. So these are the matrix for Preservé. At the moment, Motiva recommends Preservé up to 330 cc's. Some countries like Brazil still on here, if I'm not wrong, they don't sell Preservé more than, I think, 275. And my personal opinion for people at home and for you, please keep that. On your first Preservé cases, keep up to here, or maybe to here. 235, 275, 250. Don't go more than that in your first case until you learn the skin quality. There are so many variables, right, in your patients. So you want to have good results, and then you can go bigger. But I would say the first cases do up to 275 and learn. Okay, so there are many ways of using. So basically, what I do is like this. I measure the base of the breast. I take about 1.5, and then I try to fill on Preservé the remaining according to the size. I try to fill as much as I can the base, but instead I do base of the breast minus 1.5 or 2 even to choose the Preservé implant. With the Mia, it's completely different. And then as you saw, it's basically like this. You do the tumescent. Some people think, oh, the tumescent takes so long. You're going to put 250 cc. Takes a minute, 2 minutes, 1 minute per size. And then you do the incision, you do the tunneling, you do the control pocket, and then you do the implant and close. So you have all these sets, all these tools, and then we believe that the tumescent is the key. Yeah? The patient is ready. Amazing. We're just finishing this. So we believe that for those at home, lessons we learn from the Vaser people, from the big lipo people, we use double the dose of adrenaline, and then we have to wait for the tumescent to work. If you have an ultrasound, it's nice to, in the beginning, to check the infiltration with the ultrasound. So for those that are home, I hope that you get excited as we are. You saw the procedure, it's straightforward, and I hope to see you soon, somewhere in the world. Thank you.